My name is Mbae. I am a health AI researcher here at Qhala. I'll be taking you through the basics of artificial intelligence in healthcare. Thank you for joining. I really hope this session will be informative. Uh, there'll be a time to ask questions at the end of the session, and this is just an introduction to AI in healthcare. Tomorrow, Dr. Fred will be the one doing AI ethics in healthcare. And just this will serve as a foundation to key questions and issues of AI in healthcare that will be addressed tomorrow. Welcome to this webinar. I'll just start off right away. So we can start with some key statistics, uh, some key statistics about the health sector seen in Kenya and in Africa. This will again inform whether there is need to add more tools or whether artificial intelligence will be a complex solution to the problems that we do face in Kenya and in Africa. Across the entire WHO African region, health training institutions produce roughly 150,000 workers each year. However, the continent is projected to face a shortage of nearly 6 million health workers by 2030. So the number of healthcare professionals that health training institutions are pumping out doesn't necessarily meet the need. And there's a gap between how many doctors are needed for quick and fast response towards medical emergencies and to serve the population, and how many are being produced each year. Africa still carries 25% of the global disease burden. There are seven continents, let's say six habitable ones, and Africa carries a quarter of the global disease burden. However, it only has 3% of the world's health workforce. Again, the discrepancy between there's so much to treat. There's a big disease burden that Africa bears, but the health workforce is little. It's only 3% of the world's health workforce. There's also a problem where there's growth of medical knowledge. In the 1950s, it was estimated that medical knowledge is doubling every 50 years. So the next time in 2000, we will have double the medical knowledge that we had in the 1950s. But in the 1980s, it was estimated to be every 7 years. And in 2010, it was estimated to be every 3.5 years, 3.5 years. There are right now estimates that medical knowledge is doubling about every 73 or 76 days. I don't necessarily subscribe to that, but the truth is we have more medical knowledge than we have time to learn. Another key statistic is Sub-Saharan Africa has roughly about 12.5 physicians per 100,000 people. And the global average is 152,000 physicians per 100 people. This is more than 10 times less. This is about 12 times less than the global average. The last three statistics are 2.5 million deaths in Africa are estimated to be potentially avoidable. About half of those to be lack of access to health services, and the other half to be poor quality care. And we have now on the physician side, nearly half of the physicians report symptoms of burnout with excessive workload and insufficient staffing to be the primary drivers. So physicians are getting burnt out, they're getting tired. More and more we see physicians quitting the clinical practice of medicine, not because they don't like it, but it's taking a toll on their health, both mentally and even physically. And in Kenya, we have 40,000 patients, and this is now on the positive side. 40,000 patient visits across 15 clinics in Kenya, and an AI clinical decision support tool made 16% fewer diagnostic errors and 13% fewer treatment errors. Now, to let you in, this was Panda Health. They published a paper I think led by Dr. Robert Korom. And over 40,000 visits, we have a case where AI clinical decision support made 16% fewer diagnostic errors and 13% treatment errors. And this is on the positive side. Now basing on this statistic and having said this in the healthcare sector scene, could AI be a solution for African healthcare problems? Could it be a solution? Could it be the solution or a really, really good solution among other systemic solutions that can be implemented? Now, let me take you through AI 101, what AI is, before we get into the applications of AI in healthcare. Are you smarter than AI? If you were to choose one question to answer, would you pick the first question, how many dogs you can see? Or would you like to use this model to predict the number of Mpox cases in Eastern Africa that was expected between March 2025 and December 2025? Without a doubt, most of us would pick the first question. Not even without a, not most, even all of us would rather pick the first question. If you can see with me, there are two dogs on the first line, two on the second, two on the third, and then we have one dog here and three dogs, coming to a total of 10. But how did AI models perform? GPT-4, now we're in 5.5, GPT-o3 Mini, which was a really high reasoning model, and even Claude by Anthropic, they all failed. They couldn't get how many dogs there are. But in predicting the number of Mpox cases, they did it relatively better using the model simulation. Now, this is something called Moravec's paradox, and it's something that is very key to learn, even as we are looking into the applications of healthcare, of artificial intelligence in healthcare. Moravec's paradox simply is computers or artificial intelligence is finding it hard to do uh, easy things like sensory motor reflexes or perceptions. For example, perceiving how many dogs there are in this picture, it struggles with that. Things that are easier to human beings like walking, maybe noting changes in mood, moving your limbs. Those are things we find easy. They are low reasoning to us. But things like predicting or doing model simulations, they are high reasoning to us. But computers do better in the high reasoning, but in the low reasoning, like walking or uh, differentiating between a dog and a cookie, they are finding it hard. I mean, the gap or the difficulty is being reduced with training the models with a vast amount of data. But that's something that we do have. If you go to a robotics conference, you'll find the dogs or the robots are not working as fluid as human beings would. Something to note as we are about to talk about artificial intelligence in healthcare. But when do you think the first chatbot was published? Was it in the 1950s, 60s? Was it in the 2000s? Was it in the 2010s or 2020s? The first chatbot was in the 1960s, and here's a demonstration of the first chatbot. It was called Eliza. It was a psychotherapist chatbot. You can see Eliza asking, "Is there something troubling you?" And then the prompter would be, "Men are all alike." And Eliza is trying to find the connection. What is the connection, do you suppose? They're always bugging us about something or the other. Now, this was technology that was there in the 1960s. It was of course in a research institution. It wasn't open or easily accessible to the public as we do have our chatbots now. But what I'm driving to is artificial intelligence is not something that came with the 2020s. The generative artificial intelligence is something that is there, is something that boomed in the 2020s. But earlier on, we did have artificial intelligence. Now, the difference is it was mostly rule-based thinking. We thought of intelligence as rule-based. If it's not X, it's Y. If it's not a dog, it's a cat. And a computer being able to follow decision trees and come to a conclusion. And that's what we perceived as intelligence. But as we grow, or as technology grew, we are moving from that thinking to now human reasoning, where a computer is able to understand your language, it's able to learn from data, and it's able to give you relevant output based on the data it has been trained with. So now computers are almost mimicking the human brain. It's no longer rule-based intelligence, but it's now thinking-based intelligence, where there's reasoning. But have you used AI today? Uh, I mean, in this room, we can have AI companions transcribing notes. Gmail uses artificial intelligence by trying to sieve out what is junk, what is spam, what are promotional emails. Uber uses artificial intelligence to predict um, the fastest route and to come and analyze costs to apply discounts. Facebook, Netflix, and Spotify use artificial intelligence by learning what you're most interested in, how long you spend time on a particular post or video, or the comments of that video, and keep on suggesting to you uh, content that you would think you would like. So these are machine learning models that learn from your data, learn from what you like, from how much time you spend on a post, and they're therefore able to suggest to you what they think you would like. But if you're a clinician, um, do you use AI in your day? Right now, probably yes, but in 2025, in 2024, when there was still growing adoption of artificial intelligence, you'll find that there's this block in your time that you will not use artificial intelligence. It will be paperwork, it will be maybe a Google search, it will be asking your peers, but you probably wouldn't use artificial intelligence. And we've seen the health sector scene in Kenya and in Africa. But what is artificial intelligence? Artificial intelligence can be simply defined as computer systems that can perform tasks that typically require human intelligence. Now we have computers that are not necessarily doing math, adding one to one to make it two, but they are performing tasks. They are performing tasks that require human intelligence. So we're not using electricity to add calculations. We're not simply running code, but computers are able to mimic human intelligence, to reason, and to perform tasks. And this is a key application in the health sector. But artificial intelligence is an umbrella term for other niche or smaller terms. It's an umbrella term for these other terms like large language models, automation, machine learning. Um, so it's an umbrella term, and we have these other definitions. I mean, the big reason I think we are here is because with the boom of large language models. Large language models are advanced AI systems that can process and generate human text based on a large data set. So they're trained on vast amounts of data, as we will be able to see. But there's also automation. It's artificial intelligence that can automate repetitive tasks, very, very key to healthcare. They improve efficiency, they reduce human error. Humans can get bored, humans can get tired, but if a task is repetitive, it needs a bit of human reasoning, assessing whether this patient can be cleared or not, cannot be cleared, but it's kind of repetitive, it's sort of low effort. Artificial intelligence can step in into that and automate repetitive tasks. And the physician is free to do more clinically engaging things. And it's not just physicians, but clinicians, from nurses to administrators. Automation is a big, big, big MVP when it comes to applying artificial intelligence in clinical workflows. But here we have the big models sitting at the intersection of various types of artificial intelligence. We have natural language processing where computers are able to understand our natural language. We have computer vision where they're able to understand images and to make sense of videos. We have deep learning where they're learning on vast amounts of data. We have machine learning where they're able to discriminate between data points. And at the intersection of this, we do have now the generative, we do have generative AI, we do have these large language models. What's the difference between machine learning and deep learning? Machine learning is more explainable. It's based on decision trees. If it's not X, it's Y, a bit improved. But deep learning is where we are at. It's the big thing. It's where machines can learn from a vast amount of data and sort of mimic the human nerve. So I just as you can see, there's a synapse, there's the axon, and one nerve fits to another. This is what the architecture of deep learning looks like. We have the input layer where we feed a model the information, and then the first layer, the second layer, the third, fourth, many layers. And these layers are just used to discriminate, to tell how, for example, um, how a cat looks like, how the ear of a cat looks like. And the second layer might be how the tail looks like. And then now you have the output layer, um, being this is a cat or this is not a cat. So in machine learning, you do have a human helping you with feature extraction, but in deep learning, the model just learns from the data. And the quality of the data does matter. The amount of data does matter because if you give it multiple examples of a car, it's able to learn what is a car and what is not a car. And this is very important in healthcare, where the data that you train it, if you train a model on a large data set on HIV, it's able to give you better answers or better output on HIV. But if you didn't train it on tuberculosis, you're not expecting to have good output when you query it on an issue dealing with tuberculosis. Again, let's go to definitions before now we go to more practical ways where we can interact with artificial intelligence. We have large language models, as I'd hinted before. They use large amounts of data. They are trained on large amounts of data. And data here can mean text, can mean speech, images, video data, and they're trained on that. You just feed the model vast amounts of data, and they're able now to even generate their own data or even discriminate between data points. They're able to learn what is a car, what is a laptop, what HIV is, and how it comes about. And they're able to discriminate between HIV and other viral infections. We have foundational large language models. I mean, this is the reason why we're here. The boom of foundational large language models has led to a lot of interest in artificial intelligence, but they are general purpose. You can ask GPT about cars, you can ask GPT about dogs, you can ask GPT about viral infections, bacterial infections. They are they are they are masters. They are general purpose. They have mastered a couple of trades. But what if we want a model to be more precise? What if we want it to be effective? And I'll show you in an example in the next slide. Uh, I'm a clinician. I would like to know the finer details about a disease. I would like for it to come into the medical terminology. But if I ask a general purpose model to just give me the general answer, and that brings me to fine tuning, which is a big, big thing that happens in healthcare models, where you adjust an existing model on new data. And here's a visual example where a model lands on a large data set, and now you have a best LLM. You have an LLM that is trained upon a big data set, but you have this private knowledge base. You have this private knowledge base that you want the LLM also to know. So you train it further on this private or specific knowledge base, and therefore you have an LLM, the best LLM, but also knowing the knowledge base that you wanted it. Now, for healthcare professionals, this might be insurance, this might be tropical diseases. You want your model to be able to be uh, relevant to your situation or to where you want to apply it to, and that's where fine-tuning comes in. And here's an example of a fine-tuned model. If you ask GPT 5.5, what is cancer? You find it gives you a sort of general answer. Cancer is a group of diseases. Um, the body cells grow and divide uncontrollably. You'll find things like metastasis, but you find the reasons and the common types of cancer. But here we have a fine-tuned model. If you go to GPT, if you go to ChatGPT, go to GPTs and ask for a pathology model, you find Hamza's advanced pathology model as one of the top pathology models. And now if you ask it, what is cancer? You can see it's more key, it's more precise, it's more suited towards a physician or a clinician. Cancer is a group of diseases that now instead of cells grow and divide uncontrollably, you have uncontrolled proliferation of abnormal cells. You have things like genetic alterations, you have apoptosis, you have malignant neoplasms. Now, this is a fine-tuned model. It has been trained on a niche or on a private data set. It can just be training on a hospital's medical procedures or or a hospital's SOPs. Therefore, it's able to give you better output. It's able to take you through a hospital's SOPs. So, for example, you have the operating procedures of Hospital X, and it's like, point form, and you want to know what do you do in a certain situation. You train a model on the SOPs, on the operating procedures, and it's able to give you not a generic answer or what the WHO would recommend, but that hospital specifics operating procedures. And this is a good example of a fine-tuned model. And this is what we want in healthcare. We wouldn't want generic answers. We wouldn't want a one-size-fits-all model. We would want that, but only to the extent that it's precise and it's informative to our situation, to the extent that it is relevant. Here's also a really big thing in healthcare, in the use of artificial intelligence, prompt engineering. Prompt engineering, all of us are prompt engineers if you ever used an AI model where you give it prompts and it gives you an output. Prompt engineering is giving an LLM precise instructions in a format that it understands, it in a format that you give it precise instructions for you to get your precise for you to get your relevant answer. And here's the anatomy of a good prompt structure, not the perfect, but like a good prompt structure. And we will see this in the next slide. So if you can go to your preferred chatbot or large language model and sorry, let me show you an example of prompt engineering. And now this is not even for a fine-tuned model. This is with a normal. This is with GPT 5.5. I tell it to explain pneumonia and generate an image, and you can see the image it generates. It's a basic overview of pneumonia, a definition of pneumonia, and how it looks like. But here we have a fine-tuned, or rather a better prompt. You give it the role. You are a consultant pathologist preparing residents for examination. You give it the context. A 65-year-old man presents with fever, perform the following differential diagnosis, explain pathogenesis. You see, this prompt is fine-tuned. This prompt is precise. And what is the output? You have a precise case review. You have now, instead of just general pneumonia, you have lobar pneumonia. You have even a histology slide right here. You have an X-ray, and this can be used to train residents on what lobar pneumonia is. And the difference between these two outputs is not the models. The difference between these two outputs is just the prompt. Uh, so here's the anatomy of a good prompt. You give it the role. You are an experienced text author for web text. Here in the next we did, you are a consultant pathologist preparing residents for a board examination. Um, you give it a task. The task was perform the following generator differential diagnosis, explain pathogenesis, describe expected growth and microscopic findings. The context is where much of the meat is, and even the format. We solely generate an image. You can also give an example for the LLM to follow. Here's, an example if you want to try prompt engineering, try s- using an LLM to come up with a one paragraph policy for AI in healthcare. If you just tell your LLM to come up with a one paragraph policy in healthcare, it will do something generic, but add you're an experienced AI expert on health systems building, artificial intelligence, digital health, and related technologies. You're required to come up with a policy in preparation for a meeting with the cabinet on the use of artificial intelligence in hospitals, especially the level 5 hospitals. And you fine tune the prompt, and that is what separates a normal AI user from a really good AI user. In the tech world, we have junior developers and we have senior developers. Because senior developers have known um, how code works or how LLMs work. They have known, you know, the nitty-gritties, the corners, and they're able to maneuver around code. They will do an efficient prompt. It will be precise, and therefore they have their precise output. And if a junior developer and a senior developer are both using AI models to come up with code, you'll find that first the time taken might be different and the efficiency might be different. And it's all about the prompt. It's all about knowing your content, but also being precise with a large language model for you to get a precise answer. And here's a really good example. The difference between these two is just the prompt. And here's a structure that you can use when you want to be efficient, when you want relevant answers. Here, an example of few shot could be use the Kenyan guidelines on tuberculosis, use the Kenyan guidelines on vaccines, and it's able to learn from that and not give you a Reddit type of explanation or output. As I finish up with the key technologies or definition of terms, we have agentic AI models, and this will be a lot of what we find in clinical settings, a lot of what we find in outpatient settings, what we find in community settings. They are autonomous, goal-driven AI models, and they're able to perceive, they're able to reason, they're even to plan and act and learn to complete multi-step tasks with minimal or even without human input. Here's an example to understand that definition. Let's say you have a chronic disease patient. You use an agentic AI model to monitor, diabetes or hypertension readings, and it's able to alert clinicians when control worsens, when they are not complying with medication, when the sugar is high, when the blood pressure is high. So it's continuously monitoring the taking of medication. It's able to monitor your exercise. It's able to monitor the sugar levels or hypertension readings and alert. It's even able to come up with reports. You can, add another layer to come up with reports. So instead of a clinician trying to go to Excel and log in um, sugar readings, sugar level readings, or blood pressure readings, it's able to generate a report based on that and even recommend what will be the next steps. We even have a triage agent, a triage AI agent. It's able to assess symptoms in triaging and direct patients to either emergency or same day or routine care. there's need to be careful with this though, because an AI model can miss an emergency and refer to same day where the line is long and it happened to be an emergency. Okay. There's need to take care with some of these agents because especially with their sensitive nature and human, it's human life. Fatalities are terrible to say the least. But here's an agent where instead of trying to sieve or a nurse trying to sieve who sees the doctor in a high volume setting, patient setting, an AI model is able to do that in triaging. We have AGI and ASI. That's artificial general intelligence and artificial super intelligence. As of right now, Apple published a paper saying that artificial intelligence are not necessarily thinking, they're not reasoning, they're more of predicting the next word instead of reasoning as we would have wanted them to. Um, we've not reached a point where artificial intelligence is sentient, is conscious, or can perform and understand and learn the way a human can. We're not at that level. There's a lot of money and research being poured into achieving AGI, where computers might be sentient or they are on the same level as human beings. They can, they don't need to be prompted. They do things on their own. Um, um, there's a border, but you can't say artificial intelligence is sentient. And then there's super intelligence where AI can surpass human intelligence in all areas, including creativity, reasoning, and problem solving. Both of these have not yet been achieved, but there is tremendous amount of money and research being poured into this. Um, uh, AI researchers are being signed like footballers with high with contracts in the hundreds of millions of dollars. But let's say we want to build an AI model. Let's say we want to build an AI model for a clinic. We want to build an AI model for to help us in triaging. Uh, what does that look like? So let's say the building is the model that we are building. It could be a vision model where it's able to understand X-rays, able to understand CT scans. It could be a natural language processing model where it's a chatbot and it's able to understand patients talking, the elderly patients talking, or mental health patients talking to it, or a multimodal model where it has both natural processing, a vision model, and other kinds of technologies. We need to have a building plan, and that those are the algorithms. The neural networks we've talked about, the reinforcement learning, the deep learning, that's the architecture of these models, how they learn, or what they use to learn. So in building an AI model, you need algorithms. They're like the blueprints of the models. They allow AI models to learn patterns, to make prediction, and to process information. You need the algorithms. But what are they learning from? Uh, they're learning from data. Data is the foundation. It's the raw material of the building. Um, it's all about it's both quality and quantity. If the quality is indigenous, unbiased, and accurate, or the quantity, it could be synthetic data or um, or actually collected data. But data can be text, can be images, can be voices, can be videos. But just as a poor materials or inadequate materials leads to a weak building, poor data leads to inaccurate AI. Now, this is something that is essential to know with artificial intelligence models, especially in healthcare. It's something very, very key. A model is only as good as the data it has been trained with. You might have the best blueprints. You might have the best blueprints for a model, but the building, you might have the best algorithms, but the building is only as good as the raw materials and the foundation it has been built on and with. Now, uh, let's say a model has been developed in China able to detect skin cancers. Um, majority, majority of the data it has been trained with will be on white complexion. The complexion will be mostly on, you know, the skin complexion and the texture will be different from what we have here locally. So if I train a model on identifying skin cancers or skin pathologies, trained in China, can we really import that model to come and serve us here in Kenya? The answer is no. Okay. You might have really good concrete, you might have really good stone, but if we are trying to build a heart, uh, those materials might not necessarily be what we need. So even the relevance of the data uh, is in play, and how much the data represents. If you're going to import that model, it's going to have difficulty in identifying skin cancers or skin pathologies on dark skin. And that will lead to inaccurate AI models. It might lead to poor diagnosis, other legal issues. But most importantly, it's the AI is irrelevant to the situation. Here's a graph of how training data size affects the accuracy of AI models, where you have uh, if you have a small training data size, the accuracy is low. But as you continue increasing the data size, the accuracy increases. It turns up to a point where, further increase of the data size does not necessarily lead to a significant increase in accuracy. And here you have to factor in things like cost. Even in some graphs, it does go down with increase in data size, where the model is having information overload, so to say. But that depends on the model's algorithms and the blueprint. But here, training data is essential. It is essential to the accuracy. There's a direct correlation between training data size and the accuracy of AI models. Here are two things that may be of big interest to you. Uh, there's a growing need for AI talent, for human talent, for clinicians, for health system experts who understand the healthcare system, who understand diseases and patient management, but are also experts in artificial intelligence. So we have data engineers, we have data scientists, we have machine learning operatives and cybersecurity specialists. But here you can bring in health AI consultants, AI testers, ethics and compliance, personnel who are there to supervise, or first of all, from building AI models in healthcare, testing AI models in healthcare, supervising and, doing a sort of vigilance on the use of artificial intelligence in healthcare. We also have construction equipment being the compute. You'll find that there's only, as I believe, as my last research, as at currently, there's only one high performance compute in the whole of Africa, and that's in South Africa. Africa has, I think, less than 2% of the global data centers. Much of it is in the West or in China, in some Arabic countries. But Africa is lagging behind, and we have to think about, well, if we're having issues of mobile connectivity, can we really deploy and can we really deploy an AI model that needs to be online or that needs internet access? As we are building models for dispensaries, remote for remote hospitals and care centers, you need to think about mobile connectivity, whether you can do edge deployment, whether you can do offline deployment, because having internet, because of having data farms and data centers is important for artificial intelligence. It's like the construction equipment. It's like the backbone that allows the models to run. Now that's like a basic introduction to AI models. Again, we can go to reinforcement learning, we can go to vision models and their types and their uses. But this is roughly what you need to know, how about how AI works, what makes it strong, what makes it weak, before we look at the applications in healthcare. Now, AI can be applied almost everywhere in healthcare. Even things like uh, there was a piloted program where um, geriatric patients, that is the elderly, are feeling lonely, and they were conversing with AI chatbots. They're connecting with AI chatbots, and that will sort of chase away the loneliness that they were feeling. Or if they wanted to talk to someone or ask something, the chatbot will be there. Now, whether this is right, whether this goes in line with cultural or African traditional values, with what we value as a culture and as a people, is up for debate. But you can see AI is being deployed into various aspects of healthcare. And this can be clinical care. Here you have the octopus being AI and its tentacles being, reaching to various elements of AI in healthcare. You have clinical care, you have medical imaging, you have clinical documentation, pharmacy, medication and management, public health, drug development, hospital operations and clinical workflow management, population health, healthcare education, telemedicine, and remote care. These are some of the big applications of healthcare. I personally use it in healthcare education. I use a couple of models from Google's notebook or just a GPT 5.5 in my learning where I upload my notes, I upload questions, and it actually take me through the notes and ask me questions and rate my understanding. It can really ease in your time and make it faster to learn, especially with the large amounts of data that are there in medical schools. But let's look at some key applications and later on look at what AI can't do. Here's an AI-generated image of main applications of AI in healthcare. And this is almost like the format of the design. If you see this kind of design in a poster, it's probably AI generated by GPT. But again, instead of instead of maybe me going to Canva and trying to create a visual, I was easily able to do this in under 5 minutes, and I was being freed to do other things. And I didn't necessarily have maybe burnout in creating this presentation, so to say. But the first thing is medical imaging. Medical imaging. AI in medical imaging uses deep learning models. It's similar. Remember the visual about an AI model mimicking the human brain. It uses deep learning models, and it's trained on now X-rays, CT scans, MRIs, mammograms, retinal images, digital pathologies. Now here's something that's very key. You might say a CT scan is a CT scan, so we just need what? 1,000 CT scans, 1,000 mammograms, 10,000 MRIs, and it will do the job. But not only are populations different on the outside, that would be black, white, Caucasian, um, whatever, let's say, the skin texture might be, but also on the inside. We did we did we did we built a mammogram AI model, and conventional or mammogram images, sorry, uh, mammogram AI models that are trained to classify mammograms, the BI-RADS scale. If they're trained on a particular population, they will do well for that particular population. But you'll even find that the breast density varies across population. So not only like the quantity of data, but also the quality, not just like qualitatively or like how good is it, but how representative um, the images are that are going to be used in training the models. Now, the models learn visual patterns linked to disease. Um, it learns uh, it learns what cancer looks like, what gray means, what dark means, how breast density is across populations, and from that they are able to highlight suspicious areas. They assign risk scores. They prioritize urgent cases. So this can help with again, you have to be really careful with this because if an AI model does not assign maybe your case as to be urgent or being priority, and it's not forwarded for to a radiographer to approve it, then to a clinic, then to the physician, you might say that AI models, maybe with the bias within it or with the inaccuracy, led to delayed care, led to a fatality. And you have to be really careful with this. And that's something about AI in healthcare. We, on one side, want to be optimized, we want to be efficient. But on the other side, uh, it's not good, it's not ethical to take efficiency and have sacrifice, 5 cases out of 100 of missed diagnosis or delayed care. So it's a really sensitive balance, and there's a lot of work and thinking and meetings being held around AI ethics. What is the acceptable criteria? And again, we talk about AI in healthcare, thinking that it's almost as though humans perform better than artificial intelligence. But I'm forgetting the year, but the statistic is around. Uh, was it 400,000 cases in the US, and half of them led to fatalities? And it's because of doctor error. And physicians, I mean, you can blame burnout, you can blame um, high high patient load. Uh, you can blame, a doctor really needs to sleep and is tired and he might have missed something. But this is in the US and they have more doctors per capita compared to, I think all African countries. And I'm just pointing to the accuracies of some of these AI models are really high. They are almost at par with specialists or even beating specialists. Um, so an example, or rather, these are just the main ways which you can use medical imaging, artificial intelligence in a clinical setting, highlighting suspicious areas, assigning risk scores, prioritizing urgent cases, quantifying lesions, generating reports and drafts so that the radiographer is free to do more if it's interventional radiology, if they're having a um, high volume of radiological images that they have to do or they have to scan and see, it can help. It can help in easing the workload. In the next slide, we have various cases. We have various applications of artificial intelligence in medical imaging. In breast cancer screening, an AI-supported mammography detected 6.1 cancers per 1,000 women, compared to 5.1 per 1,000 using standard double reading. And they had similar false positive rates, and there was a 44.3% reduction in radiologist screen reading workload. This is according to the Lancet Oncology. Um, Here is AI sort of outperforming. Uh, on one side, it's outperforming. Like if I had two radiologists double reading, they will do 5.1 per 1,000, and the AI model did 6.1 per 1,000. And there is 44.3% reduction. So it's not 100% reduction. It's not that we are replacing radiologists, no, but there is a reduction in screen reading workload. Um, in diabetic retinopathy screening, an autonomous AI system used in primary care achieved 87.2 sensitivity and 90.7 specificity for detecting more than mild diabetic retinopathy. And this is according to the NPJ Digital Medicine. And then we have here tuberculosis, where WHO recommends computer-aided detection software as a tool for chest X-ray reading in people aged 15 years and above. This is helping bridge gaps in TB case detection. We even have, a large international body recommending computer-aided detection software as a tool for chest X-rays. From X-ray reading to pathology slides reading to breast cancer mammograms reading, AI is on one side reducing physician burnout. It's reducing physician workload, not replacing, but reducing physician workload. It's still recommended for you to double check uh, what AI suggestion, what the model is suggesting to you. But here we have very high rates. It's 7.2, 90.7, and you can say outperforming standard double reading with similar false positive rates. And again, this is bound to be more refined and to improve as time goes and as more money and research and time is being put into this. We have clinical documentation and workflow optimization, a very, very big part. This is and this medical imaging ties to African statistics about how many radiologists there are in Kenya, how many pathologists there are in Kenya or in Africa, and can we ease their workflow? Can we not overburden them? Can we make their work easier on one side, and on the other side, not replacing them, making their work easier, and improving the quality of life for physicians? And also, and even if it's possible, them handling more cases than they would have originally been able to. We have clinical documentation and workflow optimization. One of the biggest source of burnout among healthcare workers is paperwork. Paperwork, paperwork, paperwork. Generating reports, writing notes as you're seeing the patient, dealing with insurance, dealing with reports. Paperwork is a big source of burnout. From seeing the patient, uh, writing to the pharmacy dealing with insurance and approvals, uh, doing reports of the cases of M&Ms. Paperwork is a lot, and it's a big cause of burnout. But AI systems can automatically summarize consultations, generate clinical notes and reports, and assist with documentation. So what you can have is, of course, the patient has to consent to this, and there has to be a lot of guidelines per hospital, even country guidelines according to this. But you would have you would have a patient and a doctor using um I have to now on the generating notes, a doctor using like the way you would use uh, an AI companion in a Zoom meeting, in a Google Meet meeting to come up with notes for you, applying that to a doctor-patient setting where they are recording uh, the consultation, and the model is able to come up with clinical pals or clinical notes to help the doctor think through the case, and put that into an EMR system such that if you're handing over to another doctor, they're able to understand it's not written in handwriting, things are not passed by you. It's consistent. There's no boredom, there's no being tired, and you have quality data. You do have the recording, and you do have um, notes. Now it's very important for the doctor to go through the notes and add or remove where the intelligence was too ambitious or did not capture the data well. But that does help. That does help. You also have another case where uh, in in medical devices, for example, I do have a stethoscope where it's able to detect from, the ECG readings whether it's an abnormal sinus rhythm. It's able to detect really quickly and to chart out the ECG. Um, this can help in consultations can be quicker or can be faster. You're able to do more in less time. You also have a record of those things. And this is a big, big application for artificial intelligence, especially in clinical settings. So you have clinical documentation, you have more times with patients, you have, you're not writing necessarily. You're not, your time is not consumed writing or typing, but you can talk with the patient and walk them through the disease, and there's less burnout. In workflow optimization, you do have scheduling, you have bed allocation, you have theater planning. Um, i- I mean, and this can be used on one side to mitigate bias, but if you train it on, prioritize insurance patients, it can be used to instill bias. So there's also need to be careful with this. But AI models can be used in supporting appointments, in scheduling appointments, in allocating beds, in theater planning. You can even plan like a whole floor on how efficient it will be to move around, or the critical care patients are nearer the nursing desk, or where to put a maternal unit based on various reasons. Staff rostering, yeah, it can be very challenging. There are issues with bias or friction in work, but an AI model can be unbiased on that. There's also inventory forecasting, predicting drug stockouts, and even patient flow management. Patient X goes to triage Y, such and such things. There's also prioritizing urgent work, high risk patients, abnormal results, urgent imaging, uh, modeling some tasks so that healthcare teams can focus attention where it is needed most. And you can see we just have positive reviews or applications of artificial intelligence, and they are really fitting into Kenyan and African contexts. We are having few doctors. We have physicians who are burning out, where our doctors are centered in the urban centers. These applications fit our situation, the health sector scene. We have clinical decision support. Again, there's need to be very careful with this. You need to know the accuracy of the AI model. But AI systems can help identify patients of high risk of deterioration. They can recommend treatment options. They can flag potential medical interactions, and they can support triage decisions. So in this visual, you have the patient's history, medication list, imaging, and lab results. This is what we call a multimodal model because it's able to have visual results like imaging studies. It's able to have uh, text data like from your history and medication list. And having been trained on a vast data set on medicine and pathologies, it's able to and also factor in other specialty assessments, drug to drug interactions, and new prescription. And it's able to help the physician to come up with a recommended treatment plan, to flag potential medication interactions, to support triage decisions. And we're not saying that we are using the AI model, although that can be a problem. It's called over automation, where physicians are heavily relying on AI models and not thinking for themselves, or solely deferring to AI models. But we don't want drug-to-drug interactions. We don't want a lab test. We don't want for a lab test to say um, your blood volume is low or you have uh, low count of red blood cells. And then on the other side, we are prescribing drugs that will further exacerbate this condition. So, for example, an AI system might analyze patient data and alert a clinician that a patient is at high risk of developing sepsis from from things like how much urine they are outputting to their lab results to their blood pressure, and it can flag us at high risk of developing sepsis. Now we have a problem where clinicians maybe might defer to did the AI model risk that? No, then I'll not monitor you for sepsis. That can be a problem where a model is having a false positive or a false negative. So it's very important that the clinician still makes a final decision. And we want the AI, and this has to be ingrained into the hospital system, where the AI model is serving as an additional layer of support and not the one making the decision outcome. I'm not sponsored by Penda Health, but I really like what Penda Health has done. Dr. Robert Korom took me through their system, and it will flag, this prescribing antibiotics for a viral infection. It will flag it will flag ordering a UTI, ordering a urine test for for a headache. Okay, not necessarily that, but tests need to be coherent with the symptoms. Tests need to be coherent with the symptoms, and it will flag, antibiotics for viral infections. Now, will it override the clinician? No, I need this urine test. No, I need these antibiotics to be prescribed. It won't override. It will flag. Okay. What do you have on one side? On one side, you have better microbial management, antimicrobial therapy and stewardship. You also have good it's stopped being costly for the patient. It may be bad for the hospital in terms of finances, but it's not as costly. We're not ordering various lab tests for conditions that don't necessitate those lab tests. So it's very important the clinician makes a final decision and that you ingrain in the system, in what's the country's healthcare system, but also in the system of a hospital, that liability is towards the physician. There needs to be clear standard operating procedures where blame is placed, and things are even incentives and risks that the clinician does know so that they are not deferring to AI models and therefore are susceptible to the shortcomings of AI models. We have patient monitoring, and this is key, of course, in as we are having more and more wearables or online clinical device monitors. It's very key for geriatric patients or chronic patients or remote or rural patients, where vital signs such as heart rate, oxygen saturation, ECG, glucose temperature, activity, sleep, respiratory rate can be monitored real time. And therefore, you can detect risks. You can see a patient is not complying with medication. You can see the heart rate keeps on going up. You can see arrhythmias. I mean, there has been cases where the Apple Watches um, are able to alert, loved ones about um, a person's loved ones about their healthcare deteriorating or having them an arrhythmia or, a worsening chronic condition. So AI models can, monitor, they can identify risks, they can identify deterioration, arrhythmias, sepsis risk, worsening respiratory status, falls, and even poor post-op recoveries. And this can lead to faster clinical response. A big problem leading to fatalities or disabilities is delayed, delaying seeing a clinician, time taken to see a clinician, time, you stay with the disease, you brush away the headache. If it's not responded to early, the risk of disability or even death increases. And we have faster clinical response. Instead of giving raw data, you can turn it to, actionable insights or alerts. You can say, instead of as a physician having an Excel document of BP readings, the AI model is able to flag and identify like the local hospital. This patient is having readings over 160 and it's at this time of the day, or they're not moving, such and such. And it helps with continuous tracking, with early risk detection, and faster clinical response. Again, with prioritizing high risk patients, intervention, early intervention, and support clinical patient care beyond the hospital. It can also be done in a hospital setting where you ingrain these AI agents into, let's say, monitoring critical care patients, and they're able to flag, they're able to alert, like the nurse in charge or a clinician if a patient is deteriorating inside the hospital, but also outside the hospital in a remote area. Finally, we have drug discovery and research. This might not be so big in African countries. We are still importing much of the drugs, but just think about it. It takes 10 to 15 years and over $2 billion to from target identification to clinical trials. It takes that long. There are drugs which have been started in 2015 that are now coming into clinical trial. This is a traditional pathway. What a, if we use AI-accelerated pathways, there's a 70% of cost reduction. 70% of cost reduction. We also have it taking less time, 3 to 6 years, 3 to 6 years instead of the normal 10 to 15 years. So this is faster, this is less costly, and this can be transferred even to the patient where we are having drugs to be cheaper. Where, especially with molecular medicine, especially with um, chemotherapy, with cancer chemotherapy, which can be really costly. If these things are done, first of all, faster, and there's a cost reduction to them, then that can be transferred to the patient. We don't demand from the patient to pay a large amount, sum of money to have uh, the medication. And again, this can impact the economy where you have a healthier, like, you have patients are not reluctant to go to hospitals because of cost. We have a healthier population and therefore more productive population. But AI can find drug targets faster through simulations. It can analyze genetic, molecular, and disease data to identify biological targets that may be involved in disease progression. It can screen potential medicine. There's a antibiotic called abaucine that was simulated and generated using artificial intelligence, and that's like 3 years into the boom of GPT. You can imagine 7 years, 10 years. This one 3 years, it was about 2 or 1 year into the boom of artificial intelligence. Can you imagine, how many drugs are we able to uh, produce, test, produce, predict properties, and go into clinical trials? It may even be more safer for patients because we are able to predict which molecules may be able to work, be safe, bind to specific targets. We're able to predict potential side effects. We're able to simulate the drug's passage through a human body, and we're able to have both safer medicines and cheaper medicines. Uh, it's all about accelerating research and trials, and this is key. This can push Africa to be a drug manufacturer because what we time and cost. Those are time and cost are big, resources are big barriers, and if we're able to slim that, we're able to, break the barrier to entry and become our own drug manufacturers. Having said that, there's some things that AI can't do. Amongst the many applications and how positive the presentation has been on artificial intelligence, something that AI can't do. Artificial intelligence cannot understand patients the way a healthcare professional does, especially, especially, again, tying this point, the fourth point to the first, in cultural contexts. Okay. Um, Depending on on the village, you'll even find that how healthcare is practiced in Nairobi might be different than how it's practiced in Kitui, might be different in how it's practiced in Mombasa. Not of course like in there are things to do with patient management with the drugs available, but also how you address the patient, whether a female patient is comfortable with a male patient, the taboos, the discomfort. These are things that artificial intelligence might take time to appreciate and realize. And therefore, we're not saying we want AI doctors, okay? Because they're not necessarily able to understand patients the way healthcare professionals do. And there's a big aspect of of clinical care being compassion, being understanding the cues, being understanding the nonverbal cues that a patient might have. If a patient keeps on darting their eyes towards their parent, if they're being asked about drug abuse, if they're being asked about sexual, whether their sexual active status. A clinician might see that and might try to um, calmly tell the parent to join in the other room or may ask to step aside because of the discomfort. But Amori might not necessarily appreciate that. Um, First of all, in as timely as a clinician might do, it can't replace empathy. And again, this was I refer to this when talking about using chatbots for geriatric or mental health patients. It can't replace empathy. A human being, a valued human being, a valued family member or friend being there for a patient far, 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 far replaces or supersedes an artificial intelligence chatbot. So it cannot replace empathy, especially human empathy. It can try to understand, it can try to be caring in the outputs, but it can't replace human empathy. It can't give a hug the way a patient could, the way a loved one can do. It cannot um, give the assurance the way a medical doctor can do to the family. It cannot build trust um, to the extent that humans would appreciate. It cannot appreciate cultural context in the same way that humans can. It cannot. It can produce incorrect information. A precaution, but you will see even in GPT, GPT is likely to make mistakes. Please confirm important information. It can produce incorrect information. Matter of fact, it can be very confident in giving recommendations that are wrong. And this, comes, it does inherit biases from data. Not even it can, it does inherit biases from data. So again, an AI model is only as good as as the data it has been trained on. For these reasons and other multiple reasons, AI should never be viewed as a substitute for healthcare professionals. It can't be viewed as a substitute. You can't just defer to an AI model. It should be a tool. It is a tool. It should be uh, a tool that can be used to augment and make your clinical life easier, to reduce burnout, but it's not a substitute for healthcare professionals. The future of healthcare is likely, it can be, there are sort of quote unquote AI doctors in China that are being pioneered and piloted. But the future is more likely to be humans working alongside capable tools, increasingly capable tools. And the sooner we hack the balance, the sooner we are able to come up with clear procedures, the sooner we are able to come up with ethical guidelines of human responsibility, of capability of AI tools, of the line that is that needs to be clearly drawn between of automation and improving efficiency, the better we are to improve physician life, improve patient outcomes, and strengthen our healthcare system of our country. So think further. Uh, where do you see AI having the greatest impact in Kenyan healthcare? Where do you see, sorry about this, is being in Kenyan healthcare. Where do you see AI having the greatest impact in your practice? What tasks, after learning how AI learns, what it can do, what it can't do, where do you think it will help you the most? And also looking at it from a macro level, what AI governance challenges might limit this potential impact? Are you having rigid supervisors? Is the country not moving at the same pace as technology is? Are there lengthy times that it may take to come up with supervising bodies, or it might take a lot of time to come up with clear guidelines? If you want to learn further on artificial intelligence in healthcare, here are some resources. If you want to be a coder more on the tech side, there's DataCamp, there's Coursera, there's YouTube. But if you want to learn more about ethics and governance, more about its use, more about examples, there's Coursera, there's WHO. WHO has, I think, a couple of courses, if I'm not wrong. Ethics and governance of artificial intelligence has documents on this. There's the Lancet Digital Health, away from pathology and case studies. Now we have like the Lancet Digital Health. You have the New England Journal of Medicine AI. We have Deep Learning AI, and there's an AI for medicine specialization, among other courses. But how would I start if I was to start again? Do a YouTube search, do a Google search, and then find your niche, or find what you will be interested in. If it's um, clinical care, clinical decision support, public health, population monitoring, such and such. And from that, just look for not necessarily go for a data camp or a Coursera subscription, or do the Stanford AI in healthcare specialization. Just do a Google search and YouTube search on what you would like to do or what is happening, and then just do a deep dive on that. You can find courses on Coursera, but it's good to get your niche because it is very varied, from building the AI models, testing them, compliance, ethics. AI in healthcare is very wide. Finding your niche and getting specialists from there. Senior positions might require a master's in digital health, in data, or in public health, again from reputable institutions. So that has been my presentation. Thank you for attending. Are there any questions? Um, Please type them in the chat if you would like.